Good afternoon, everyone. Thank you for coming on this really grim-looking day. It looks positively New Englandish to me, or possibly Londonish anyway, fog and rain and all the like. For those of you who don't know, my name is Pat Thomas. I'm the director of the Health and Medical Journalism Graduate Program at the Grady College of Journalism and Mass Communication. And this is the 10th year that Grady College and the Center for Tropical and Emerging Global Diseases here at UGA, part of the Franklin College, that we've had this lecture series. My co-conspirator and co-organizer, Dan Colley, is right down here. He's waving his hand now. Dan's just made his way back in the traffic from an appointment in Atlanta, so he's going to stay where he is for right now. But he's given me the fabulous task of kicking off this 10th series with a speaker whose presence means a lot to me. I want to take you back 30 years. It's April 15th, 1985. Most of you were not born. Some of you were. I know who you are. It's at the World Congress Center in Atlanta. It's April 15th. Millions of Americans rushing to mail their tax returns. But inside, I believe it was the East Concourse on the 3rd floor. It's a little bit after lunch. And in room 331, I think it is, the lead speaker was a man giving an invited presentation called The Epidemiology of AIDS in Homosexual Men. This was our speaker today, Harold W. Jaffe, who was one of the physicians and epidemiologists who figured out, through their painstaking work, how this virus, which we now call HIV, but it wasn't called that back then, how this virus was transmitted and what would be reasonable practical steps to slow its transmission. Meanwhile, catty-cornered across the hall in room 313, was the press room for the world's first International Congress on Acquired Immunodeficiency Syndrome. And I was in that press room. And near me in that press room was Randy Schultz, a man from San Francisco who went on to write a book called And the Band Played On. And in that book, one of the characters is, our speaker today. And that movie was, of course, that book was later made into a movie, which he's going to talk to you today about reality and media and the early days of the AIDS epidemic. So let's welcome Dr. Jaffe. Thank you.
Well, thanks very much for the invitation. It's great to be here, and particularly great to see my former CDC, Dan Colley, who's been under the weather but was able to make it here. And the weather is terrible. Having spent 6 years in England, I felt very comfortable, but for Southerners, it's probably not so nice. Although HIV/AIDS is certainly a global disease, the focus of my talk is actually not on the global aspects of the disease, but in fact about what went on in the early days of the epidemic in the United States. And in fact, at the time that we started these investigations here in the US, we actually had no idea at all what was going on in Africa. I'm going to try to do this, look back through both a lecture, which I hope will be more or less factual, and also, as Professor Thomas mentioned, using some clips from the film And the Band Played On, which is less factually correct, but I think is a good illustration of understanding some of the main events of the time. As she mentioned, this book was written by Randy Schultz, who was an openly gay reporter for the San Francisco Chronicle. The book was published in 1987, and it was released as a film by HBO in 1993. The film uses actors, some of whom you'll recognize playing the part of people who were actually involved in some of this early work. And I've listed some of the characters that you'll see in the film. Jim Curran, who was my boss at CDC at the time, the director of our task force. Jim is actually now the dean of the School of Public Health at Emory University. A group of medical epidemiologists, Don Francis, who you'll meet, was the lab chief, Bill Darrow, a medical sociologist, Selma Dritz from the San Francisco Department of Health, and Michael Gottlieb from UCLA Hospital in Los Angeles. Since we're talking a bit about the media, it's important to point out, I think, that the roles of these people in this film are quite distorted, particularly Don Francis and Jim Curran. Presumably this is for dramatic purposes because films need good guys and bad guys, but that really wasn't the case during the investigations. The film starts with a scene from the intensive care unit at UCLA Hospital in November of 1980. And the scene is of special interest to me and special meaning to me because I was a house officer at UCLA and had left that training program and working in that unit just 6 years before these events. So let's go on to the first clip from the film. Well, the article was published, and you'll see that it didn't have the word homosexual in the title. It was published in the CDC Morbidity and Mortality Weekly Report on June 5th, 1981. And as mentioned in the film, this article described 5 previously healthy, young homosexual men who were all treated for biopsy-proven what was called pneumocystis pneumonia, which is a very rare malignancy, a very rare kind of infection at 3 different hospitals in Los Angeles. 2 of these men had already died. This report was very strange in several aspects. First of all, this infection, pneumocystis pneumonia, is called an opportunistic infection. And that means it would occur typically only in persons who had some obvious cause of immune deficiency, such as having received cancer chemotherapy or an organ transplant. But these men had none of those risk factors. Secondly, we didn't understand why all these cases were in homosexual men. And thirdly, why were these cases being seen in Los Angeles and possibly New York and San Francisco? Just a month later, the mystery became even more mysterious. And let's go to the next slide to show you what happens. Now this is just a month later. This is July 3rd, 1981, and a second report is published in the MMWR. This report describes additional young, previously healthy homosexual men, not just from California, but also from New York. Some of these men had this pneumonia, pneumocystis pneumonia. Some of them had what are called other opportunistic infections, things like cryptococcal meningitis or cerebral toxoplasmosis. Again, infections that are very rare except in people with an immune deficiency. And then the most unusual thing of all was that some of these men were also developing a malignancy called Kaposi sarcoma. Now, up until this time, this was a very rare malignancy in the United States. It had been described about 100 years earlier by a dermatologist, Moritz Kaposi. And the disease he described, and the one that's described by the character in the film, is a disease that occurs mainly in elderly men and was rare. In the mid-1970s, there were only about 300 or 400 cases a year in the United States. When it did occur, it was usually in men of Southern European ancestry or Ashkenazi Jewish ancestry. And this is what it looked like. I think I saw one case in medical school, and it looked exactly like this. It was an older man who had this kind of purple plaque lesion on the lower extremity, which is for some reason a very typical location. And as mentioned by the character in the film, this disease progressed very slowly, if at all. And if you read the textbooks of the time, they would say that a patient typically would die with this disease rather than from this disease. Sometimes it didn't need to be treated at all. Sometimes it was treated just with local radiation. This was what we were seeing in these young homosexual men. Now, if you did a biopsy and looked at both forms of the disease, they'd look exactly the same under the microscope. You wouldn't be able to tell the difference. But clinically, they were very different. The form that we were seeing in these young gay men was much more aggressive than the form seen in the elderly man. If you saw this patient in clinic, he might have 2 or 3 of these skin lesions one week. A few weeks later, he might have 5 or 10. And a few weeks later, it might look like this. And the disease was not limited to the skin. So here's an example of a patient who has this oral lesion that's Kaposi sarcoma. Sometimes these would occur in the gastrointestinal tract, in the stomach, the esophagus, or even in the lung. and they would bleed, and some patients, in fact, would die from that bleeding. So this, again, was very unusual. Now, there was one clue when we looked at the literature on this malignancy, and that is if you look at what happens to people who receive organ transplants, particularly kidney transplants over time, who've had to receive these immunosuppressive drugs for years and years, they do develop some unusual illnesses, and one of them is this malignancy, Kaposi sarcoma. So there was something about the immune system and this malignancy, although we didn't understand really what the relationship was at the time. Now, up until this point, in the midsummer of 1981, we were simply relying on physicians calling us and saying, you know, I think I saw one of those cases that you're describing, a young gay man with this disease or that disease, and maybe that's what you're looking for. So we decided that we really needed a case definition. We needed to say, here's what we're trying to find out about. So we made one up, and this is the definition we made up. You'll notice that the disease didn't have the name AIDS at the time. In fact, it didn't have any name. We called it KSOI, just meaning Kaposi sarcoma, or one of the list of opportunistic infections. So we said what we want to know about are patients who have this malignancy or one of a list of life-threatening opportunistic infections. We want previously healthy people. We didn't want older people because of the possibility we pick up the Kaposi sarcoma that occurs in that age group. So we wanted people less than age 60, and we didn't want individuals who had some obvious cause of immune deficiency. So we said, this is what we're looking for. We made this case definition available to health departments, to major teaching hospitals, to infectious disease doctors, to dermatologists, oncologists, and said, if you see this, please report it to your local health department, and they'll report it to us, and in fact, they did. So this is an example that was provided to me by Dr. Jerry Friedland, who was a doctor working at Montefiore Hospital in New York City, of a hand-drawn, what's called epidemic curve, showing you the cases in the United States by their date of symptom onset. The cases in the crosshatch are the cases that were reported from New York City, and the cases in the clear parts of the bars were the cases from other parts of the country. Well, let's move ahead now to a bit later in the summer of 1981. Well, some of the older members of the audience may recognize the actors in this scene. There's Sir Ian McKellen and Lily Tomlin and Phil Collins. The actor who played me is named Charles Martin Smith, whose previous big role was Terry the Toad in American Graffiti. So it's obviously typecasting. This scene was actually based on a visit that Bill Darrow, the research sociologist you'll see later in the film, and I made to the club baths in Atlanta. For reasons still unknown to me, Bill Darrow knew the owner of the club baths. And we wanted to go because of a couple of reasons. One, we had heard anecdotally that a number of the early cases were men who had frequented bathhouses. And secondly, we'd heard that a lot of them used these poppers, these inhalants. These are used to enhance gay sex and could be bought in different forms. You could buy them in these labeled bottles like Locker Room, which is a good name because they smell like sweat socks. In fact, when we were at the club baths, it was popper night. You could get them for 50 cents off. But then we also discovered that in gay bookstores and bars, you could buy these very mysterious-looking brown bottles. And we thought, well, what's in this stuff anyway? And is it possible there's something that's immune suppressive in there? And could that explain the epidemic? And if we pull this stuff off the shelf, that'll be the end of it. So we bought some of this. I remember putting a vial of it in my refrigerator at home, and my wife didn't find that very amusing. We had them analyzed by the CDC laboratories to see what they contained, and they actually had what they were supposed to have, either amyl, butyl, or isobutyl nitrite. They didn't have any contaminants. And we also did some additional laboratory experiments exposing laboratory animals, I forget whether it was mice or rats, to vapors from these materials to see if they were immunosuppressive, and they weren't. So it doesn't mean that these poppers played no role at all, but it wasn't going to be so simple as saying, that's it, let's just get rid of them. Well, let's move back to CDC, and now it's in the autumn of 1981. The case control study is kind of a classic method in epidemiology. It consists of looking at people with a disease, they're the cases, and people without the disease, they're the controls. And then looking backwards, looking at what they were exposed to, what they did, and trying to find differences that might indicate what's the cause. Selecting the cases for this study was pretty simple. We would just pick individuals who'd been reported with Kaposi sarcoma or pneumocystis pneumonia. But it wasn't so obvious how to get the controls. We debated, should we have men and women, just men? Should we have straight men and gay men, just gay men? We ultimately decided that we would try to recruit controls who were gay men matched by age within about 5 years, by the city of residence, and by race. But how to find them wasn't so obvious. So we kept talking about how are we going to do this. One idea was, well, let's go to the cases and ask them to name their gay male friends who were not their sexual partners. And it turned out less than half of them could do that. So that was probably a clue right there. So what we decided to do was, first of all, go to the practices of private doctors in those cities that had primarily gay male practices and said, can you talk to your seemingly healthy patients about this and see if they'd be willing to be interviewed by us? And that was very helpful. Secondly, we went to public venereal disease clinics and tried to do the same thing. Now, we knew that there would be a bias there. I mean, a man going to a sexually transmitted disease clinic must be pretty sexually active. But we figured it's pretty easy to do this. We had contacts in all these cities, and we'll just have to take that into account when we do our analysis. We did all the interviews in person, as you'll see in the next scene. I want to know why Richard Gere didn't play me. I just have to live with that disappointment. Mary Guinan only had her underwear stolen, not all of her clothing, and we didn't interview Richard Gere, but the rest of the scene is pretty realistic. We did interview men in cheap hotels, because I think our per diem at the time was about $25. The desk clerks were puzzled by why all these young men were coming to see the CDC doctors. But despite the surroundings, we were, I think, very pleasantly surprised to find out that these men were very willing to share a lot of details of their lives that you would otherwise not hear about. And I think that the reason was fear, that many of these men had friends who were sick. Some of them had died of the disease. Others were worried that they had it themselves, and they really wanted to get to the bottom of it and wanted to help us. So the next few slides show you some of the data that we got from this case control study. We were able to enroll 50 cases, and you can see they came from New York, San Francisco, Los Angeles, and a couple from Atlanta. About 3/4 were white. That was the demographic profile at the time, although that's not true today. And here's some information comparing those 50 cases to these two control groups. So again, the clinic control group is public sexually transmitted disease clinics, and the private group would be patients seeing private doctors in those same cities. You can see that the cases were more likely to have gonorrhea or syphilis than either of the control groups. They were more likely to use different kinds of street drugs. And the use of the poppers, the nitrite inhalants, was really universal. Pretty much everybody was using them. When we looked at more detail at sexual practices, we found some big differences. For example, on average, the case patients had about 60 different sexual partners per year. That was more than twice as many as either of the control groups. And again, realize that the clinic control group was coming from STD clinics. If anything, they'd be very sexually active, yet the cases had more than twice as many sex partners. On average, about half of their sex partners were coming from the bathhouse, much more than either of the control groups. And they tended to have sex at a slightly earlier age than the other men in the study. When we finally published the results of this study, though, we were cautious. It looked to us like the main differences were related to sexual behavior and possibly a sexually transmitted behavior. But we said that we thought that the occurrence of these diseases in homosexual men was associated with certain aspects of their lifestyle, that the biggest difference is related to sexual activity, but drug use was very highly correlated. so that men who were very sexually active were also using a lot of drugs. And we couldn't say for sure that drugs weren't playing a role, and that's the kind of problem you run into sometimes in these kinds of studies. Now, I want to show you the only clip that I've got that doesn't come from the film. It comes from an NBC news broadcast done at the time. And I'm showing it to you because, one, it shows you how this study was reported in the media. Secondly, it gives you a chance to meet the real Bobby Campbell and the real Jim Curran, who looks very young in this film and doesn't look much different today. And also gives you a clue about what's going to come next. Well, as mentioned in the news broadcast, we had heard actually from David Auerbach, who was a CDC physician assigned to work in Los Angeles County, that there were cases occurring there that may have been sexual partners of each other. And that obviously would be very important to try to figure out. Dr. Auerbach had never done that kind of investigation before, going out and asking people about their sexual partners, and asked if we could send somebody to help him. So we sent Bill Darrow, our research sociologist, who had a lot of experience in that kind of interviewing. So the next clip will show you what they found. I found an old interview that Bill Darrow gave about this investigation, and he said, well, these three men, they'd never met, they'd never had sex, yet they named the same guy in New York. I actually dropped my pen. Auerbach's mouth was just hanging open. He practically fell off of his chair. So these are the slides that Bill Darrow showed us when he came back from California. So here's the first part of the cluster. Gaetan Dugas indicated as the out of California KS case, and you can see him linking together this cluster of cases in Southern California. And here he is at the middle of another cluster, linking 4 cases in Los Angeles to 4 cases in New York. And then the slide that you saw in the film, he's at the middle of this cluster, linking together 40 cases in 10 North American cities. Now, we called Mr. Dugas patient 0 in a publication just to indicate 0, 1, 2, 3, 4, et cetera. The U.S. media, when they read about this or heard about it, jumped on it, and they said, patient 0, that sounds like the guy who brought the infection to North America. We never meant to say that, and in fact, it's almost certainly not true. In fact, we've looked at the viruses that infected Gaetan Dugas versus other early cases in the United States, and they're ones that appear to be genetically earlier than his, although his was one of the more early infections. I think it's fair to say, though, that men like Mr. Dugas, infected with whatever it was, we didn't know what it was, who were highly mobile, highly sexually active, frequenting bathhouses all over the place, could easily have spread a sexually transmitted infection to gay men throughout North America. And it's also interesting that I believe 2 other men in the cluster were also flight attendants. Now, for reasons not known to me, CDC medical epidemiologists often keep their notes in these little green laboratory notebooks. I have no idea why. Dan Colley is laughing. I don't know. Maybe he knows why. I don't. In any case, this is a photo from my green book that was dated November 1982. I've covered up the patient's name, but the notes describe a call that I received from Dr. Arthur Amon, who's a very well-known pediatric immunologist at University of California, San Francisco, who was asked to consult on a boy who was born in March 1981. This boy had what's called Rh disease, where the mother has antibodies against the red cells present in the baby and destroys them, making the baby very anemic and requiring large amounts of blood. And that was the case in this child. Following discharge after all these transfusions, this baby started developing some very peculiar infections and was clearly immunodeficient. Now, sometimes children inherit immune deficiencies from their parents, and Dr. Amon had literally written a book about this, and when he went to see this child, said, you know, this doesn't look like any kind of what's called congenital immunodeficiency to me. What it looks like is AIDS, except no one's ever described AIDS in a child, so how could that be? He also found out that all the blood that was received by this young boy was collected at Irwin Memorial Blood Bank in San Francisco. And the last clip that I'm going to show you is a highly fictionalized account of the investigation of this transfusion event. You'll notice that Dr. Amen has been morphed into a woman, played by Angelica Houston. You'll hear terms used that we never use. GRID refers to gay-related immune deficiency, which we didn't use. You'll see that the disease AIDS is named at this meeting, which it wasn't. So it's probably the least factually correct of all the clips I'm going to show you, but it is good in that it shows you the kind of emotion that surrounded the issue even now. Well, as I mentioned, this particular clip is not very factually accurate. Don Francis made many impassioned speeches during his time at CDC, but he didn't make that one. And as I mentioned, the disease wasn't named at the meeting. But I think the clip does give you an idea of how difficult this issue was. So at the time of this meeting in January 1983, we had several cases where we were convinced these were cases resulting from transfusions. We also had cases in persons with hemophilia who we thought were infected with something through the use of the blood products that had to be used to treat their disease. And we thought the point of the meeting, which was with blood bank directors, the National Hemophilia Foundation, the Food and Drug Administration, was to say, okay, it's happening. We don't know what it is exactly, but we've got to do something about it. For example, we should have gay men defer from donating blood. We maybe should screen the blood supply for antibodies to hepatitis B because that seems to correlate with whatever this is. The blood bankers said, no, we don't buy it. We don't think it's a real disease. We're not doing any of this stuff. Now, trying to take their side, which I don't really take, perhaps they were legitimately concerned about creating a blood shortage, that anything that was done to discourage donations might do that. But I think the real reason was denial. What we were saying, after all, was what you're doing, which is important and necessary to save lives, is also putting people at risk for a disease that we don't understand, except that it's almost always fatal. So their attitude was, we're not going to do anything. Fortunately, private discussions held over the next few months were a lot more productive. And in March of 1983, the U.S. Public Health Service published for the first time recommendations to prevent the disease that now was called AIDS. So these recommendations said that there are certain groups of people at increased risk, those with signs or symptoms, their sexual partners, sexually active homosexual or bisexual men with multiple partners, Haitian entrance to the United States. Now, this was very controversial. We knew that the disease was occurring in Haiti. We knew that Haitians living in New York and Miami were getting it, but we didn't know why. So we couldn't say, well, let's be sure that certain Haitians of a certain age group or sex or some other characteristics not donate blood. We didn't know what it was. So we made the decision to say Haitians should not donate blood. Now, I'm sure that resulted in discrimination against the Haitian community in this country. But from a public health point of view, I think it probably was the right decision. Hemophiliacs and sexual partners of people at increased risk. We said to avoid getting this disease, to avoid having sexual contact with persons known or suspected of having it, having multiple sexual partners increased the risk. And here we said, as a temporary measure, groups at increased risk should refrain from donating blood or plasma. Now, within a year, there was the first blood test available to screen for the disease, and that test became more and more sensitive and specific over the years. So it was possible to relax this criteria over time. So, for example, Haitian Americans are now perfectly free to donate blood. However, the one exception has been gay men. Up until now, any gay man who says that he's had sex with another man since 1978 is not permitted to donate blood. Now, some of you may have read in the newspaper that the Food and Drug Administration is considering revising this to say the only gay men who will be deferred are those who've had sexual contact with men in the last year. Whether that will be adopted or not, I don't know. But right now, there's still a restriction. Unfortunately, delays in implementing these recommendations proved to be very costly. In the United States, there were multiple lawsuits brought against blood banks for not doing anything to prevent the transmission of the disease. In other countries, the consequences were even more severe. For example, in France, blood banking officials who made the decision to use contaminated blood products went to jail. But I think what's impressive about these recommendations is that they were essentially correct, and they were all made without knowing what the cause of the disease was. I think it illustrates the power of an epidemiologic method to understand and even prevent a new disease without knowing its cause. It wasn't until the spring of that year that Luc Montagnier and his colleagues in Paris reported finding a novel retrovirus in the lymph node of a gay man living there. And it wasn't until a year later that Robert Gallo at the National Cancer Institute really established that this was the cause of AIDS. Montagnier was awarded the Nobel Prize in Medicine in 2008. Now, I'd like to tell you that the story ends in 1983, but you all know that it doesn't. So let me just show you a few slides about the spread of the disease in this country. So each dot on this map represents 30 cases of persons reported with AIDS. By May 1985, there were the first 10,000 cases in the United States. You can see they're concentrated in New York, Miami, Los Angeles, San Francisco. If we jump ahead to the summer of 1989, there are now 100,000 cases, lots of cases in Puerto Rico, Seattle, Dallas, Houston, Chicago, Atlanta. And then by the end of 1995, the first 500,000 cases. And really at this point, every major metropolitan area in the United States had large numbers of cases. And then skipping ahead another 10 years or 15 years to 2010, you can see a case total of over 1 million with more than 600,000 deaths. As I mentioned at the time we started these investigations, we had no idea that other parts of the world were going to be affected, but of course they were. So here's a slide from the WHO showing you the situation in 2013 with an estimated 35 million people infected worldwide. About 30 million people have already died of the infection. Now, these numbers are important to know, but they're not the whole story. They're not the human part of the story. So I want to end by showing you the last clip of the film that I think does do a good job of showing you that human face. It shows you people, some of whom you know, some of whom you may have heard of, who either had the disease or were advocates. I don't know who all of them are, but I'll tell you the ones that I do know. And that's it. So thank you for your attention.